Record. I think I'm now recording, right?
Yeah. Now you're recording.
Okay, so we shall start from here. Okay, they can always watch the recording from this part. So when it comes to the development of the respiratory system and also the development of the digestive system, the first thing which you should review or which you should understand is the concept of embryonic folding. Okay, so that this concept you are taught under general embryology. You are taught the two types of folding, the cephalocaudal fold or the longitudinal fold, and the lateral or transverse folding. So you should understand the outcomes. What are the outcomes of this folding? One of the outcome of the embryonic folding is this. So note that, okay, this here is the conceptus. There, that's the gastrula, the trilaminar embryo is over there as an ectoderm, okay, in that color, that ashen like color there, whitish something. Then in gray is the mesoderm, and in yellow is the endoderm. So that's the trilaminar embryo. So this is the events which occur in week 3. Okay, so in this embryo of ours is flat. It's flat. It's like a pancake. It's a flat structure. But we can all agree that ourselves, we are not flat structures. We are cylindrical structures. Okay. We are also, we have a kyphosis. Okay. So how did you convert this pancake-like structure to now the definitive fetus? One of the folding which occurs is what is known as longitudinal folding, or folding along the craniocaudal axis. So this is the cranial end. That's the cranial end. That's the caudal end. So you can see that you have a head fold. So that's the head fold, and that is the tail fold. So this folding is the longitudinal folding, or the cephalocaudal folding, or the craniocaudal folding. Can someone just put in the chat box, what are some events? What are some events which occur? What are some events which occur due to craniocaudal folding? What are the outcomes? Someone in the chat box. Yes, these things you are taught, we are recapping. We are recapping. So, we are recapping. So, telling me, we are just recapping. Hey, what is happening? Nobody is typing in the chat box. Guys, type. I can see Onyango, heart tube descends, very good. Same to Hope. Pericardial cavity becomes cranial to septum transversum, very good, Joy, very good. So yeah, I can see you remember some of the outcomes, but are these the only outcomes? Why are you just telling me in relation to the heart? What are the other outcomes? You should know at least 10 outcomes. Yes, very good, Hope. The future brain moves cranial. Okay, that is very good. What else? What else? There are about 10 events which are outcomes of the cephalocaudal folding, and only see 3. What happened to the other 7? Very good. The allantois connects to the hindgut. Very good, very good. Establishment of the anterior and posterior body axis. Okay. Division of the yolk sac. Very good. Division of the yolk sac. Fusion of the heart tubes. Well, is fusion of the heart tubes and also the division of the yolk sac. Are those outcomes of craniocaudal folding, or are they outcomes of lateral folding? Increase in length. Okay, we will agree with that. So the craniocaudal length of the fetus increases. Okay. So I can see you have known some. So let us discuss this. So you can see that during this is now the craniocaudal folding. During this craniocaudal folding, the dorsal part of the ox sac. Remember, this is the ox sac, okay? That is the ox sac. So the dorsal part of the ox sac is incorporated into the embryo, whereas the ventral part is left out. So you can see that we have this part now connecting the part of the yolk sac incorporated into the embryo, and the ventral part that is known as the vitelline duct. That's the vitelline duct. So when we discuss the development of the digestive system, I do not expect to come back to this story because I'll have described it. And now this dorsal part of the yolk sac, which is incorporated into the embryo, is divided into three parts. The part which is near the cranial end is the foregut. The part which connects to the yolk sac is the midgut. And the part which now connects to the allantois is the hindgut, okay? So this dorsal part of the yolk sac is divided into three parts, and the foregut will give rise to the foregut derivatives. So the structures of the GIT tube from the esophagus, so that is from the pharyngoesophageal junction to the level of the second part of duodenum. So anything from the esophagus to the second part of the duodenum came from the foregut. Then from the second part of the duodenum to the right 2/3 of the transverse colon, so the right 2/3 of the transverse colon came from the midgut. The hindgut is everything else. So the left 1/3 of the transverse colon, descending colon, sigmoid, and the upper part of the rectum. The anal canal does not come from the hindgut, and rather comes from a structure known as the proctodium. Okay, the proctodium. We shall discuss that when we do the digestive system. But for now, I need you to understand how the foregut is formed, because it is from the foregut actually that the respiratory tree will, the lower respiratory tree will be derived from. So just to put that in another perspective now, to show the lateral folding, you can see that in this, okay, let me start at A. You can see you have the trilaminar embryo, ectoderm, mesoderm, and the endoderm. And then you can see that neuronation is taking place. Here you have formation of the neural groove, and you can see that we have the segmentation of the mesoderm to form now the paraxial mesoderm, which will give rise to the somites. The intermediate mesoderm, which we will discuss it when we discuss the development of the genitourinary tract, and the lateral plate mesoderm. But note something interesting also is occurring here. Now, you can see we have intercellular cavities are being formed in the lateral plate mesoderm, and those intercellular cavities fuse to give rise to the intraembryonic coelom, or the intraembryonic body cavity. And it is this intraembryonic coelom, this coelom which gives rise to the body cavities, the three body cavities, the peritoneal cavity, the peritoneal, the pericardial, and the pleural cavity, okay? So those cavities are derivatives from the intraembryonic coelom. But the lateral plate mesoderm is further divided into two. So we have a part which is intimate to the ectoderm. So that part which is intimate, let me use red. That part which is intimate to the ectoderm. Ectoderm is in blue. That's the somatic layer. And this other part which is now intimate to the endoderm, that's the splanchnic layer, okay? So the reason I'm repeating this is because these are actually the tissue origins of the various parts of the respiratory tree, and also the GIT. Okay, so I think I have tried to emphasize on that. Allow me to hide this. It's blocking my view. Oh, what happened? I stopped sharing. Okay. Mhm. Okay. Where were we? Yeah, it's back. Okay, let me hide this. Hide floating. Okay, let me hide those. Now, next we discuss the embryonic origin. So when asked what is the embryonic origin of an organ, we simply need to tell us the site and the tissue of origin, okay? The tissue of origin or the source of mesenchyme, okay? So when asked the origin of a structure, always remember the three S: site, source of mesenchyme, and the sequence of formation of that organ, okay? So what is the site here? So let me, so just other images to emphasize what you have been showing you. So you can see here we have lateral folding. So that is lateral folding. You can see the lateral folding. You can see that the dorsal part of the yolk sac is incorporated into the embryo. The ventral part is not, but initially you have a connection, what is known as the vitelline duct or the vitreointestinal duct, one and the same thing. And then you can see once the lateral folding is done, you can see that actually you have formation of the primitive gut. Now the primitive gut is the one which is divided into the three parts: the foregut, the midgut, and the hindgut. But of importance to note is that you can see that the gut here is suspended into the cavity. So this is the gut. You can see that it is suspended within this cavity, what I'm naming as the intraembryonic coelom. So what is suspending it is the dorsal mesentery. Okay, so let me erase that. Okay, but you can see this. So in what color is that? Somehow red, but not red. I don't know what color that is. So this represents that dorsal mesentery is part of the splanchnic. That's part of the splanchnic mesoderm. Okay. Also, you can see that lining the gut wall itself, we have splanchnic mesoderm. Then the gut itself, the inner part is lined by endoderm, represented by yellow. Okay. So you can already guess the source of the tissue of origin. You can already guess the tissue of origin of these structures, which are derivatives of either the primordial gut. And the primordial gut will give rise to the digestive tract and also the respiratory tree. Okay, so let us talk about it. So the endoderm, which lines the inner part, will give rise to the epithelial lining. Okay, so in this case, we are talking about the respiratory epithelium and also the glands. Okay, then the splanchnic mesoderm to the outside now. You remember when you discussed the anatomy or the histology of, or if you have not discussed it, the histology of the GI tube. Those tubular structures have four layers. You have the mucosa, the submucosa, the muscularis externa, and the adventitia. Okay, so this mucosa, the epithelial lining comes from the endoderm together with the glands. Okay, so those mucosal glands in the respiratory tree will come from the endoderm. The splanchnic mesoderm will give rise to the connective tissue elements. So anything to do with starting from cartilage. So cartilage will be coming from the splanchnic mesoderm. Smooth muscles, those smooth muscles of the muscular coat. But now you need innervation, and for innervation, the neurocrest cells are the ones who do this work, the neurocrest cells. And the site of origin of the respiratory tree, the lower respiratory tree, is actually the ventral foregut. So from the ventral foregut, the medial parts of the ventral foregut, that is where you usually have a diverticulum known as the respiratory diverticulum, which eventually gives rise to the trachea. So the larynx, the trachea, the bronchi, and everything else until you get to the alveolar sacs. Okay, so let us discuss the sequence of events. So initially, you had the gut tube. Let me draw a gut tube, the primordial gut tube. It was just one tube, okay, like that. So this is ventral, this is dorsal. Now, from the ventral part, you get an outpouching. So from the ventromedial part, you get an outpouching, what is known as the respiratory diverticulum, okay? What is known as the respiratory diverticulum. So this respiratory diverticulum is actually which we give rise now to the larynx, the trachea, everything else, and everything else distal to the trachea, the bronchi, the bronchioles, and whatever. But now, you know, even from your cadaveric gross anatomy, you know that the trachea and the esophagus are two different structures. They are separated. You saw this even in histology. Okay, so how does this separation occur? This is why you need this process known as foregut septation. So foregut septation is necessary to split the airway from the esophagus. So you want air and food or drinks to move in two different channels. You don't want food to go to the airway. That would cause choking. Okay, or air. Okay, air can go to the the esophagus. That has no issue. And, you just belch the air. But the issue is food going to the airway. That is dangerous. That can cause choking and death. So how does this process occur? The process of foregut septation involves the formation of what are known as tracheoesophageal ridges. Okay, so you form coronal. So you can see that initially you had this one tube there, but then from the sides you form tracheoesophageal ridges, and these tracheoesophageal ridges grow towards each other. You can see these ridges. Okay, so they grow towards each other and fuse at the midline, and now they completely separate the esophagus, which will be posterior, and the trachea, which will be anterior. Okay, so they fuse and they form a septum. Okay, the tracheoesophageal septum, and this is complete by the 6th week, the day 42. Now, I want you to think of what could go wrong. What could go wrong here? Because that would be important. Okay, so next, how do the trachea and the larynx develop? Once the respiratory diverticulum has formed, it elongates distally. Okay, you can see it is elongating, it's growing downwards. So it elongates distally, and at the distal tip, you have two distal outpouchings. So at the distal tip, initially it was just a single outgrowing, single outpouching, but then the distal tip divides into two. Okay, what are known as the bronchial or lung buds. Okay, you can use some texts tell you there is a difference. Some use the terms interchangeably and also use the terms interchangeably. So bronchial or lung buds, okay? So the proximal communication, however, so this communication, remember, as much as you are carrying out septation, this foregut septation, at the most proximal part, you don't want the communication to be sealed off, okay? So the proximal communication with the primitive pharynx is the upper part of the esophagus remember pharynx leads to the esophagus, right? So that part where the respiratory diverticulum connects to the primitive pharynx, that part, the communication, there is no septation at that part. And this remains as the laryngeal orifice. And the adult derivative of the laryngeal orifice is the laryngeal inlet. So you don't want foregut septation to completely separate the trachea from the primitive pharynx. You don't want that. You want an inlet to remain, okay? So at this point, no septation will occur to allow for communication, okay? So I want you to think in the line of what could occur if now there was complete septation, even at the place where the future laryngeal inlet should be. What could happen? How will this present, okay? Then for the larynx, remember, as we said when discussing the laryngeal, rather the pharyngeal apparatus, remember the sixth arch, we said it contributes to the muscle and the cartilage of the larynx, okay? So I won't repeat on this, we have already done that. So that is how foregut septation occurs. Now, Okay, let me see if you have questions. What will I see now? And yet I have, ooh, okay, now I think I'm messy. Uh, what is happening? Yeah, I think I knew someone would had ask a question. Let me recap that. What is happening? Hello, guys, is my screen still visible? I can't see my screen from my end. What is happening? Is my screen still visible from your end, guys? Too zoomed in. Let me correct that. Uh, Let me stop sharing. Uh-huh. Uh-huh. Okay, what is happening? Oh my. Let me just stop sharing. Uh, okay. Can you see it now? Is it? Oh, no, it's not. Okay. You can see my. Is it still zoomed in? Okay, let me see. Okay, I can see yes, I can see it's okay. So my presentation is visible. Okay, I think I can also see it now. Uh, okay, where is that? Oh, huh. Oh my. I think I just have to share my entire screen at this point because uh, it's giving me a lot of. Oh, it's fine now, eh? Can we all see the screen? But now I can't see the. Okay. Is it fine now? Can everyone see? Thank you. So, uh, Abigail can't. Eh, Can you see the screen? Let us first answer that. Can you see the screen? Okay, thank you. So now let me now address these questions which are coming in. Okay, I think I'll have to move this down here. Let me now address the questions. Okay, let me see these questions. Is the respiratory diverticulum same as? I think no. I will explain that again. Uh, oh, guys, you can't hear me. You mean it has already started raining wherever you are? Where do you guys live? Is the communication at the level of the larynx meant to allow for speech? Well, that communication, I'm talking about the laryngeal inlet. It's more of air. Remember, air comes from the nasal cavity through the nasopharynx and the oropharynx. That air has to go now to the larynx. So the only way it can go to the larynx is if you have a communication. Okay, it's more of a communication to allow for passage of air from the oropharynx to the larynx. Okay, I think we can now proceed if you allow me to do that. Please tell me if you don't, if I stop sharing again, it might happen. So the one asking if the respiratory diverticulum is the same as tracheoesophageal ridges, no. The respiratory diverticulum is this outpoaching, that's the respiratory diverticulum. But for me to separate this outpoaching from the foregut, or rather what will form the future, this would be the future. Okay. This will be the future esophagus. This will be the future esophagus. So for me to now separate this respiratory diverticulum, which will give rise to the larynx and the trachea, I need to form a wall, septum between the two. And for that septum to form, I start with the tracheoesophageal ridges or the esophageotracheal ridges. Does not matter how you name them. So those ridges are simply, they are, as the name suggests, they are just ridges which meet at the midline and fuse to form the tracheoesophageal septum. And that septum now separates my trachea from my esophagus. I think whoever had asked that question, I hope it is answered. Now, what are the phases of development of hollow structures? Any hollow structure, and here the structures I'm talking about are one, the GIT structures, the respiratory tree structures, also the tubes, the hollow structures, the tubes be it in the genital system, okay, in the genital system or in the urinary system. So these phases will apply, okay? So two phases. One, we have the solid stage and the recanalization phase, or the solid phase and the recanalization phase. So in the solid stage, so remember what we said about those hollow structures. To the inside, they have endoderm, and then, so if we use that in another, so to the inside in red is the endoderm, and in blue is the splanchnic mesoderm, okay? So this is the splanchnic mesoderm surrounding the endoderm. Now, what happens in the solid stage is that we have rapid endodermal proliferation. The endoderm proliferates at a faster rate than the splanchnic mesoderm. And what this means is that there'll be accumulation of these endodermal cells. So the endodermal cells in red will start to accumulate. They accumulate. There are very many. And what happens eventually is that they occlude. Okay? They cause luminal occlusion. Okay? So they occlude the hollow structure. So that is the solid phase. What happens next is the recanalization phase, where now these endodermal cells, which had occluded the lumen, they undergo apoptosis and they form vacuoles. And these vacuoles are the ones which now fuse to form the hollow, to rather restore the hollow configuration. Okay, so these stages of solid stage and recanalization phase occur in all hollow structures. So I want you to think in the lines of what could go wrong. What if recanalization does not take place? If recanalization does not take place, I'll not have luminal continuity. I'll have atresia. What if canalization takes place, but it's incomplete? I'll have stenosis. Think about how those anomalies could come about. Now, development of the lung can be divided either according to the time period or according to the morphology. So according to the time period, you just have two periods, the embryonic period and the fetal period. As you know, the embryonic period will start from week 3 and end around week 8. Fetal period will start from week 8 and go until week 36. Okay? Is it no, 38, sorry. Week 38, eh? Okay, now there is someone who is requesting to record from their computer. I'll send the recording, worry not, eh? Now, So the time period, this is easy. This is the easy one, but it is not used in anatomy, okay? This one, you'd use it in other instances, but the one preferred for anatomy is the morphology, according to the morphology. Now, in this stage, we have an embryonic stage, okay, same as that one. Then we have a pseudoglandular stage. So we have 5 stages. So the first stage is the embryonic phase. The second is the pseudoglandular stage. The third is the canalicular stage. So as the name suggests, canalicular, you are carrying out canalization. So if canalization is taking place during the canalicular phase, that tells you that during the pseudoglandular stage, this is a solid stage. Okay, there was no luminal continuity in the pseudoglandular stage. The lumens are established in the canalicular stage. And then you have circular stage. As the name suggests, you are forming alveolar sacs. And then we have alveolar stage. Now, alveolar stage, as you can see here, starts prenatally. It starts around week 36, but spills over postnatally, okay? So it spills over postnatally. In fact, most of the alveolar stage takes place postnatally, okay? The other thing which I need you to note is the timing. The embryonic stage will start at week 3 and at week 8, okay? The pseudoglandular stage, as you can see, does not start at week 8. It does not start immediately. It started before. You can see the take-home message is there is an overlap. There is an overlap of these stages, okay? There is an overlap. It's not like the lung waits for one stage to end for it to begin the other. No, you'll find some parts of the lung are in the embryonic stage, others are in the pseudoglandular stage, okay? So these things are not, they do not take place sequentially. Rather, it's a simultaneous process where there is an overlap, okay? There is an overlap between some of the stages, okay? And these timings are also not cast on stone. The timings, these 3 to 8, you might find other texts telling you other authors from different papers, from different books telling you this will start from week 3 end to week 9. Okay, so a week or so won't harm. Okay, so these timings are not cast on stone. They change depending on the author. Okay, so let us discuss those stages. What occurs in the embryonic stage? Or rather, in fact, let me go back here before I move there. So see what happens in the embryonic and pseudoglandular stage. That stage is known as organogenesis. So in those stages, you form the lung. The lung is already formed in those stages, or rather, most of the part of the lung is formed. Then the canalicular stage, circular stage, and the alveolar stage are differentiation stages. Now here, you have formed a lung, which is an organ. But now you have to carry out the differentiation. Now, rather the specification of this lung for it to perform its intended function. So what happens in the embryonic phase? There is foregut septation, we have described that. Bronchial bud formation, we have described that. But also, you have formation of the main pulmonary vessel. The take-home message here also, from now on, in each stage which we will discuss, the accompanying pulmonary vessels will be formed. So in the embryonic stage, where you form the bronchial buds, you also form now the 2 pulmonary arteries and the 2 pulmonary veins, okay? So you form the pulmonary, rather, let us stick to the arteries. You form the 2 pulmonary arteries, okay? The right and the left. So the right pulmonary artery will follow the right bronchial bud. The left pulmonary artery will follow the left bronchial bud, okay? So every stage at which these bronchial buds divide, also the vessels divide. So what dictates the division of the vasculature is the division of the bronchial tree. So as the bronchial tree divides, so if you had, that's the trachea, those are the bronchi. So if this is the left principal bronchus, you know it will divide to a superior lobar bronchus and an inferior lobar bronchus. So if the pulmonary artery was there next to it, it will also divide in the same fashion, okay? So if this is the right principal bronchus, it will divide to the superior lobar bronchus or the epithelial bronchus and the bronchus intermedius or the hypathelial bronchus. The bronchus intermedius, you know, will give rise to the middle lobar bronchus and the inferior lobar bronchus. So the right pulmonary artery will also divide in the same fashion, okay? So the bronchial tree is what fits the division of the pulmonary vasculature. And now what happens in the pseudoglandular stage? There is extensive branching. There is extensive branching where you have formation of the conduction zone. So the conduction zone is formed during the pseudoglandular stage, okay? So the principal bronchus, I've gone back to the embryonic stage. The principal bronchus, which will come from the bronchial buds, that is the first generation of the bronchial tree, okay, or the respiratory tree. Let us say the respiratory tree. It's the first generation, okay. So the conduction zone extends from generation 1 to generation 16. The 16th generation are the terminal bronchioles, and that is where the conduction zone ends. Conduction zone is the zone in which no gaseous exchange takes place. It's just conduction, okay? Air is just being conducted. That's the conduction zone. The respiratory zone, which now extends from generation 17 to 23, that is now the respiratory zone, where now gaseous exchange takes place. So formation of the conduction zone will be complete by the end of the pseudoglandular stage. Also, as I had mentioned earlier, the accompanying blood vessels will form. And this is a solid stage. So as these bronchi and bronchioles, as they divide, they don't have a lumen per se. They are obliterated, okay? They are obliterated. Now, what happens next is now you need canalization, okay? So here you have airway canalization. So remember, in the pseudoglandular stage, it was a solid stage. So you need to now restore the luminal patency. You need to restore the luminal configuration. So canalicular stage takes over. And also in the canalicular stage, apart from that, you have formation of the respiratory zone. That is from the 17th to 19th generation, okay? So from the respiratory bronchioles to the alveolar ducts, especially the respiratory bronchioles. Major of the respiratory bronchioles are formed in the canalicular stage. So this is now a common thing, okay? But now, important to note is that the airway in the canalicular stage is lined by cuboidal epithelial cells. Remember when you discussed if you have done the histology of the lung, you must have been told the alveoli contain 3 types of cells. We have what are known as type 1 pneumocytes, type 2 pneumocytes, and type 3 pneumocytes. Now, the type 1 pneumocytes are those squamous cells, those flattened squamous cells, okay, which form part of the blood-gas barrier, the air blood-gas barrier, okay? So type 2 pneumocytes, on the other hand, you are told they are the ones which now produce surfactant. So this tells you that surfactant production begins in the canalicular stage. So even if you have a premature delivery, if the fetus is already within the canalicular stage, especially the late canalicular stage, that is from week, say, 24 onwards, there is a good chance that that child might survive because surfactant prevents collapse. You'll be taught in physiology, I think in year 2, not in year 1. Surfactant reduces the surface tension in the lungs. By reducing the surface tension in the lungs, the alveoli are kept open even during expiration. So you prevent alveolar collapse. That is the function of surfactant by reducing the surface tension, okay? So even if a child is born, especially in the late canalicular stage, around week 24, they can survive with ventilatory support. They might survive with ventilatory support because they have surfactant. That way, they can their lungs can't collapse. Okay, so this applies for our setting. 24 weeks is the minimum age at which a fetus might survive in third world countries, including Kenya, or developing countries. In developed countries, such as even the States, even at 20 weeks, the fetus will be fine. Okay, so that tells you about the canalicular stage. Now, the other stage is the circular stage or the terminal sac stage. Now, this is you can see that this now here are cuboidal. So this is this stage here is still canalicular stage. This is still canalicular. But now, see what is happening. We have ballooning. We have ballooning of the terminal ends of the airways. So these terminal ends of the airways balloon out. Okay, so they balloon out to form these squamous cells, which are now the type 1 pneumocytes. And occasionally, the type 1 pneumocytes make contact with the capillaries to form a primitive blood gas barrier. Okay, primitive blood gas barrier. Okay, so more alveolar sacs and ducts form also, and a fetus might survive. Even the fetus will survive in this stage even without ventilatory support. Okay, a fetus will survive in this stage even, especially the latter stages. They will survive even without need of ventilatory support. They might survive on their own. Okay, so depending on the amount of surfactant which has been produced, if it is much, they can survive without ventilatory support. If the surfactant amount is less, they need ventilatory support. Then we have the alveolar stage now, where we have continued thinning of the alveoli and expansion. So here you are just forming alveoli, okay? You are forming alveoli. So you have continuous thinning of the respiratory membrane. So that primitive blood gas barrier. So air will be here in the future. This is blood. So this is the blood gas barrier, okay? So this barrier is what thins out, okay? It thins out. You want to decrease it as much as you can so that you decrease the diffusion distance for air. So there is also further surfactant production, increased capillary network, as you can see, and this extends into the postnatal life. In fact, most of the alveoli are formed in the postnatal life. So during birth, you usually have 50 million alveoli. Okay, during birth, you have 50 million alveoli, but that is just a sixth of the total number. A sixth of the total number. Okay, so most events, an N should be there, most events occur in the first 2 years of life. So an adult lung has 300 million alveoli, and this number is achieved by the age of 9 to 10 years. Okay, so but in the first 2 years of life, of postnatal life, that is when most of the 300 million alveoli are actually formed. So that is the alveolar stage. It extends up to even the age of 10 or 9 years. But most of the events occur in the first 2 years. Okay. Now, during development, our lungs are not filled with air. They are filled with a fluid, what is known as fetal lung fluid. And it is produced by the fetal pulmonary epithelial cells, those pneumocytes. Now, this fluid is at a higher pressure compared to the amniotic fluid. So if the fluid in the lungs is at a higher pressure compared to the amniotic fluid, there'll be fluid efflux. Fluid will be regurgitated from the lungs. So that tells you that because fluid is coming from the lungs into the amniotic fluid, and remember, part of this fluid, the fetal lung fluid, includes surfactant. Part of it includes surfactant. So that tells you that if you carry out an amniocentesis where you draw the amniotic fluid and analyze it, if you analyze the levels of surfactant, you can be able to determine the fetal pulmonary maturity. You can be able to tell if the fetal lungs are mature enough to if there is a premature delivery, and those is the surfactant in these lungs of this premature fetus, is it enough for it to handle external environment? Will the lungs be able to carry out inspiration and expiration without collapse? Okay, so you can be able to tell that. But the fetal, yourself and myself, we do not have lung fluids. Otherwise, if you have fluid in your lungs, that is pulmonary edema, which is not a so good thing. It might be even the beginning of the end. So you don't want fluid in the lungs in the adult. So that tells you that it has to be removed after birth. And how is it removed? Most of the fetal lung fluid is actually removed by pulmonary circulation or by lymphatics. But if there is a delay, this might cause what is known as transient tachypnea of the newborn, okay? And this transient tachypnea of the newborn is most commonly seen in cesarean delivery, okay? So those infants who have vaginal delivery, they have time. During the vaginal delivery, they have time for this pulmonary fluid, the lung fluid, they have time for it to be absorbed. By the time they are coming out, all of it is out of the lungs. But in a cesarean delivery, it's just an abrupt session. Even the fetus was not even was not planning to come out at that time. It was just to get out. It was evacuated of the uterus. So even the fetal lung fluid was still not yet absorbed. But during a vaginal delivery, it's actually the fetus which now wants to evacuate itself from the uterus, and it has to prepare itself. And one of the preparation, it knows that in the external environment, the lung fluid will not be suitable for the external environment. So a vaginal delivery, the fetal lung fluid is absorbed. It has sufficient time for absorption. Now, here we are. Now, I am sure we have gotten to the exciting part, the part where now you answer these questions. Allow me to join using my phone, my other device, so that I can see your answers. Can see your answers. Yes, I expect you to have been start by naming which anomaly is this? 1, 2, 3, 4, 5, 6. So just no, you hear the echo. Okay. Yeah, I think you can't. Can you hear any echoes? Are there any echoes? Hello? Ah, great. Yes, yes, now that's okay, the no's are enough. Yes, so 1, choanoatresia, very good, Emmanuel and J, very good. 3, right pulmonary hypoplasia. Okay, okay. Right pulmonary hypoplasia for 3, we can agree with that. 4, tracheoesophageal fistula, very good. 6, pulmonary hyperplasia. Okay, 6, pulmonary hypoplasia, okay. 2, tracheomalacia, very good, Rosa, very good, very good. 5, what is 5? 5, CPAM, congenital pulmonary airway malformation. Is it? Is it CPAM? Is that the congenital pulmonary airway malformation? Is it? Is it? Very good. B and Sadiq, very good. That's a bronchocyst. That's a bronchocyst. Okay. So I think you have told me those anomalies. So I'll just show you the names very fast and we proceed. So that's choanoatresia. In that choanoatresia, you can see that we have this is a soft tissue structure within the choana, the boundary between the nasal cavity and the nasopharynx. So this is the nasal cavity, NC. This is the nasopharynx, NP. So you have that boundary, the choanas are occluded. What you might not know is that this might not be compatible with life, especially for newborns. Newborns are obligate nose breathers. A newborn does not know how to breathe using the mouth. They just know how to breathe using a nose. So if they have a choanoatresia, they might die, because even if the mouth is okay, they don't know how to use the mouth for breathing. Okay. 2 is tracheomalacia, as shown here. You can see that this is an endoscope of the trachea. So you can see the C-shaped tracheorhins. You can see them. But what do you notice is that this is during expiration. So this is during inspiration. During expiration now, the trachea is collapsing. As you know, the trachea should not collapse, whether during expiration or inhalation. It should remain patent. So this collapse of the trachea during expiration is what is known as tracheomalacia, and it is due to immaturity of the tracheorhins. Now this here, Okay, let me show you. So tracheomalacia, that's the spelling. Now, this actually here is right pulmonary agenesis. So this here is the left lung. On the right side, there is nothing. But what has happened is that the left lung has actually undergone what is known as compensatory hypertrophy. Because the right lung is not present, the left lung being present, it now becomes very big in size to compensate for the right defect. And for that reason, part of the left lung actually might cross the midline and extend also to the right side. Okay, so that's pulmonary agenesis. Now, you said this is TOF, which is very good, but I want you to please go and find out the types of TOF. You can see you have type A, B, C, D, E. Can you be able to name this? Okay, can you be able to name this? So like type A, in this type A, you can see you have esophageal atresia. EA is esophageal atresia without negative tracheoesophageal fistula. So that's type A. So maybe a question to you, of these types, which is the most common? Of these types, which is the most common? Which is the most common? Very good. C for C. Okay, so type C is the most common. C for common. Okay, so that's the most common, and it is a esophageal atresia with distal tracheoesophageal fistula. So the way these guys will present is that one, because they have an atresia, there will be regurgitation. Okay, so if they'll be regurgitating content. So if they breastfeed, they regurgitate the milk because that milk cannot go to the stomach because there is a stenosis there. So rather, not a stenosis, rather an atresia. Two, because they are breathing through the airway, which is okay, the air will go to the stomach. So they'll have distended abdomen. Okay, distended abdomen. Yes, food comes out. That's regurgitation. But also remember, every day we produce 1 to 2 liters of saliva, and this saliva, most of it is swallowed. So if you cannot swallow the saliva will just come out of the mouth. So there'll be drooling of the saliva, okay? So of this, type A, B, C, D, E, which do you think is the most dangerous and why? Okay, I can see all of them are saying type B, but okay, we might agree type B is dangerous, and also type D. Also type D is dangerous because also in type D you have a proximal tracheoesophageal fistula, and this means that food in the esophagus will go to the airway and cause choking. Of this, which one would be subclinical? Which one will be subclinical? Which one will be detected last? Which one will be the last one to be detected? So subclinical means it's very hard for you to detect it. It will be detected later on in life. Very good, type E, okay, type E. So in type E, there is no esophageal atresia, so no esophageal atresia. That means food will go to the stomach. There is only a tracheoesophageal fistula, okay? So that means that, in fact, most of the times it is air which will go to the esophagus, okay? So type E is the one which will present later on in life. So TOF may occur as a standalone lesion. It might occur just alone, but in most cases, it occurs as part of what is known as the Bactrian syndrome. Now, the Bactrian syndrome is a combination of syndromes which affect the vertebra. So you have vertebral malformation, A, anorectal malformation, C, cardiac malformation, T, trachea, E, esophagus, so tracheoesophageal fistulas occur there, R, renal, L for limb anomalies, okay? So Bactrian syndrome. So whenever you see a TOF, whenever you see a tracheoesophageal fistula, you should have a very high index of suspicion of the Bactrian syndrome. You should look for vertebral malformation, say a hemivertebra. You should also look for anorectal malformations such as what are known as rectovaginal fistulas or an imperforate anus. Look for cardiac malformations. Look for tracheoesophageal malformations will be TOF. Renal malformations such as horseshoe kidney, limb malformations as we discussed. So it might be part of that syndrome, or it happens in most cases, or a stand-alone lesion, just occurring alone. So that's bronchogenic cyst. It is due to abnormal proliferation of the foregut. Okay, so you just have an abnormal proliferation of the foregut. In most cases, it is asymptomatic. It might be asymptomatic. It is not presenting with any syndromes. But now, if it is very big in size, it might actually compress structures. It might even compress the aorta, might compress nerves, and now that is what will bring the patient. Or it gets infected. If it gets infected, these cysts do not, remember, a definition of a cyst is simply a collection of fluid in an enclosed cavity. That cavity does not have any communication. Okay, so in cases of infection, these cysts might establish communication. They might establish communication with the airway, and that might bring about issues, because if they have a fluid, the fluid might enter the airway, and that might cause even aspiration of fluid, and that is what the patient might present with. That is pulmonary hypoplasia. Okay, and I want you to discuss, okay. Yes, please discuss the causes of pulmonary hypoplasia in your own free time, okay? But when discussing the causes of pulmonary hypoplasia, restrict yourself to 3 events. So think about pulmonary blood flow. So if you have a vascular an insult to the vessels, so the vessels are damaged, which supply the lung, that lung might not develop. 2, think about fetal lung fluid. You need this fetal lung fluid is needed for lung maturity. So in cases of oligohydramnions, they might present with pulmonary hyperplasia. Okay. So regarding pulmonary hyperplasia, please go and read about Porter's syndrome. Porter's syndrome. What are the features of Porter's syndrome? One of the features was pulmonary hyperplasia. Okay. Then think about this lung of ours. For it to develop, it requires a space. So if you have decreased thoracic space, that might cause a pulmonary hypoplasia. Okay. Now these are other anomalies. Okay, I'll just discuss these ones. Now in this one, you can see that this side of the lung, actually, okay, this is the left side. You can see the left side, that's the right side. Now, you might be tricked to think that the right lung is not present. It is actually, you can see the shadow. It's shadow there. It's just that. But the left lung is so big. What is happening here? So what happens here is that you might have a check valve mechanism. So within the airway, anywhere within the airway, especially in the bronchus, you might have a valve. This valve allows air to enter. So that valve allows inspiration, but does not allow expiration. So that means that air would simply accumulate in the left lung in this case, and that will cause hyperinflation. So they do what is known as congenital lobar hyperinflation. And due to this hyperinflation, this lung will become so huge. You know, a lung is simply like a balloon. Simply like a balloon. It is just increase in size. And as it increases in size, it causes the mediastinal structures to shift to the right. And as these mediastinal structures shift to the right, they cause that lung of the right side to be compressed there, okay? Then we have what are known as bronchopulmonary sequestrations or pulmonary sequestrations, okay? And these are simply, as indicated here, they are non-functioning mass of lung tissue. So you can see here we have a section of the lung, and also this one. It is not connected to the bronchial tree. It is not connected to the tracheobronchial tree, okay? But it receives arterial supply, okay? So they are of 2 types. It can either be extralobar, as shown here. Extralobar pulmonary sequestrations have their own pleural investment. So they have their own pleura. But intralobar, they are within the lung, and but they do not, so they are invested in the lung pleura, but they do not connect to the tracheobronchial tree. Okay, so you can live with this. Okay, there are simply some incidental findings. Okay, they do not present with any syndromes at first. Jerry, please pardon the first reason. Ooh, which first reason? Where? Which reason? Where was I giving reasons regarding the pulmonary hypoplasia? Okay, I think that is it. So the first reason which I said is a vascular insult. So remember what we said during formation of the lungs, you start with the bronchial buds. So bronchial buds, which we now divide into the other parts. But as I was describing this process, I was saying the accompanying vessels form. These accompanying vessels are there to feed the cells with the nutrition. Remember, even these fetal cells require nutrients for them to proliferate. Now, I want you to imagine any event which might cause that vessel, which is to supply that part of the lung, if that vessel is injured or occluded or anything causes this vessel not to form. If the vessel does not form, that lung tissue, which was to be fed by that vessel, also that lung tissue won't form. So you'll have pulmonary hypoplasia. Is that clear, Jerry? Or who had asked the question? Oh, it's Abigail. Okay. Okay. I think. Okay. Now, this one. 1, 2, 3. Okay, 3 I've named for you. But tell me another name of 3. This 3 is the respiratory distress syndrome. What is the other name? Other 2 names. What are the other 2 names? Let's start. Yes, give me answers. 1, 2, 3. Give me answers, guys. Guys, answers. Answers, bwana. Aha, very good, Adrian. Very good, Hope. Very good work. Yes, the other name of respiratory distress syndrome of the newborn is hyaline membrane disease. The hyaline membrane disease. Hyaline membrane disease, or I can see, in fact, Obed Onya. Obed has told us the other, in fact, accurate name. That is the most accurate term. That is the term which is now being used. It seems Obed is even in clinical practice. We have a degree. The surfactant deficiency syndrome, very good. Surfactant deficiency syndrome, very good. And as the name suggests, surfactant deficiency syndrome. In this case, surfactant is not present. So what happens to these guys? So when they are born, whenever they try to exhale, the alveolar collapse. Okay, the alveoli collapse, and that causes respiratory distress. Okay, what about 1 and 2? What about 1 and 2? Tunafaa kujua hizi zote as first year. Sadiq, I was a first year and I knew all of them. Why not you? Sadiq. Yes, you should know all of them. Yeah. What is the name given to number 1 and 2? Why are you not talking? Guys. Ati wewe ni another case. What do you mean I'm another case? I was just a first year like you. Not in another case. Aha, very good. Yeah, you can see even they know. M and Abigail. Very good too. That is the pulmonary artery string. So look at this. Okay, this is the left lung. That's the right lung. Okay, so what is happening here is that, okay, this here is the ascending aorta, AA. This is the descending aorta, okay. But now, what do you see here? PT, that's the pulmonary trunk. The pulmonary trunk here, you can see that instead of it giving the left pulmonary artery, the left pulmonary artery should come from that part. What happens here is that the pulmonary trunk gives rise to the right pulmonary artery. This is the right pulmonary artery, okay? But you can see that from the posterior part of the right pulmonary artery, the left pulmonary artery comes from that part. That's the left pulmonary artery. And it is forming a sling. This structure here, the dark structure, that's the trachea. And there is a structure which has now collapsed here. Remember, this is a vertebra. You can see the vertebral body here. The vertebral body, you can see the vertebral foramen there. You can see the rib, part of the rib there. Okay, you can see part of the rib. So the structure which should be here should be the esophagus, but the esophagus has collapsed. This left pulmonary artery has formed a pulmonary sling, which passes between the trachea and esophagus. So the way these patients will present with, they will present with compression symptoms. So if the esophagus is compressed, they present with dysphagia, difficulty in swallowing. They might also present with dyspnea because at times the trachea might be compressed. So difficulty in breathing, okay? So that's how they present. So that's the pulmonary artery sling. How does it come about? It is thought to be due to involution of the sixth arch artery. See, this sixth arch artery is the one which gives rise to the left pulmonary artery. So if this involutes, that left pulmonary artery is not formed, but now it takes origin from the right counterpart, okay? One, CPAM, very good. Wall P, whatever that is. Mkono majina fani sana. Yes, this is CPAM. Congenital pulmonary airway malformation. That's the name, congenital pulmonary airway malformation. CPAM, congenital pulmonary airway malformation, not congenital polycystic lung. Close but not correct. It's the congenital pulmonary airway malformation, and it is due to abnormal proliferation of the terminal respiratory unit. So that terminal respiratory unit, it proliferates abnormally, and the way it presents with these cysts, macrocyst and some microcyst, okay? It presents as cystic structures without a proper alveolar formation, and you can see it there, okay? On the left lung, there you can see it, the congenital pulmonary airway malformation. So there is abnormal proliferation of the proliferation of the terminal respiratory units. Okay. Yeah, I think those are the anomalies. Now in this one, see this. So this is the left principal bronchus. Okay, which one is this? Which one is this? Anomaly. Which anomaly is this as I name this structure? This is the left principal bronchus, and then you can see it divided into the superior lobar bronchus and the inferior lobar bronchus. But you can see that in one of the segmental bronchus, it's obliterated. So which anomaly is this? Very good. Ado, very good, very good. Together with apical, very good. Bronchoatresia. So bronchoatresia, remember what we said in the solid stage. So failure of canalization at that point meant that the luminal continuity was not established. So the part distal to that occlusion, you can see we have accumulation of mucus, okay? So mucus tends to accumulate in that part, and now the problem comes if it becomes infected, okay? If it becomes infected, but that is how bronchoatresia presents, Yeah, I am done with the development of the lung and the anomalies of the lung. It's 9:20. Oh my. So I want us to speak about the development of the diaphragm in 15 minutes because this is very fast. Diaphragm, this is the anatomy of the diaphragm. You remember the diaphragm? It has parts, central tendon of the diaphragm. It has a muscular part, but the diaphragm has opening. It has the cavo opening on the level of T8. Acha niwaandikie msiseme Kuambiwa. What is happening? It seems something has come. Okay, something, don't know why there was some music in the background. Okay, let me share once again. Where is that? Yep, share, very good, nice. You can see the screen, eh? Can see the screen, eh? The diaphragm, you can see it. Eh, kwani mumelala bwana? Can you see my screen? Thank you. Now, remember the openings. We have the cave opening at the level of T8, esophageal hiatus T10, aortic hiatus T12. Then around the esophageal hiatus, you have the crura, the right crus. Remember, it's the right crus of the diaphragm which forms that esophageal sling. Eh? It's the right crus of the diaphragm. Here you can see the left crus, that's the right crus. And then you can see other muscles of the posterior abdominal wall, such as quadratus lumborum, the psoas major. Then you can see the medial arcuate ligament, medial arcuate, lateral arcuate ligament. Remember the structures which pass underneath each of these arcuate ligaments. And then just above the aortic hiatus is the median arcuate ligament. Yeah, that's it. That's the diaphragm. Now, how does it, that's just the anatomy. Now, how does it develop? Easy. You know, when I was in the lab last week, but was it last week or the other week before? I was asking the members of tables 1 to 4 on Tuesday and tables 9 to 12 on Thursday to tell me the development of the diaphragm. Maajabu. Nobody would tell me. Let me teach it so that next week, when I come there and okay, next week, if you have your exams, if you find it there, you won't, burnt. I hope you won't burnt on that one. Okay, so let us discuss it. So what is the embryonic structure and what is the attached derivative? Eh? I think this is what you need to understand. The cervical somites, the myotomes, give rise to the muscular part of the diaphragm. The septum transversum gives rise to the central tendon. The pleuroperitoneal membrane gives just a very small part, a very small part. It gives rise to a very small part on the posterior and the peripheral part of the diaphragm. The dorsal mesentery of the esophagus, which is also known as the dorsal mesoesophagus, gives rise to the crura, and the body wall mesoderm gives rise to the peripheral posterolateral portion. Okay, so if you understand this table, you're fine. You're fine. Yeah? I'll be fine. So let us see actually how that happens. So you can see the septum transversum there. Okay. Initially, there is usually a communication between the pericardium and the peritoneum, and also the pleural cavity. So there is initially a communication between the thoracic cavity and the abdominal cavity through this canal, what is known as pleuroperitoneal canal. The canal which allows for communication between the thoracic cavity and the abdominal cavity. But with time, this canal has to be closed, as you know. The diaphragm has to close out. So it has to separate the thoracic cavity and the abdominal cavity, okay? So the structure which does that in the embryonic or in the fetal diaphragm is the pleuroperitoneal membrane, okay? You can see the pleuroperitoneal membrane. fuses with the septum transversum to obliterate that canal. But important to note is that this canal first crosses on the right side. It first crosses on the right side, then the left side closes later. So the closure of the pleuroperitoneal canal on the right side occurs at an earlier event. It takes place first compared to the closure of the left side. That would be important. Okay. Then as development continues, the pleuroperitoneal membrane is simply a membrane. It is replaced by now muscular ingrowth from the body wall. So you can see this lateral body wall. This is the body wall. You can see that we have muscular ingrowth now in purple. You can see muscular ingrowth. And the adult diaphragm here, the adult diaphragm actually, most of the posterolateral parts are actually derivatives from the lateral body wall, the mesoderm of the lateral body wall. Remember what we say about the innervation of the diaphragm. The peripheral parts of the diaphragm are innervated by intercostal nerves. This is from the understanding that the peripheral parts, those parts actually came from the lateral body wall. And as they came from the lateral body wall, they carried along their nerves. And this, in this case, will be the intercostal nerves. So I think I have mentioned this, the source of the development, so source of mesenchyme, and the part of the diaphragm. So please understand this image or understand that table. Now, what are some defects? What are some defects which could occur? One is this one. Can you name this one? 1, 2. Name one. Yes, Victor. The pleuroperitoneal canal is actually also referred to as pericardioperitoneal canal. In fact, if you might want to say pleuropericardio-peritoneal canal, fine. From the idea that it connects the 3 cavities, okay? So what is 1? Yes, 1 is congenital. 1. What is 1? Congenital diaphragmatic hernia. Yes, 1 is congenital diaphragmatic hernia. Guys, 1 is congenital diaphragmatic hernia, okay? That's a congenital diaphragmatic hernia. What about 2? Now 2, as Rosa had said, I think it was a typo. Now that is the eventration of the diaphragm, but that's the eventration of the diaphragm. Now, in the eventration of the diaphragm, there is a membranous structure. There is a membranous structure. It's not a hernia. There is a membranous structure separating the abdominal organs from the thoracic organs. Now, here, the membranous organ, there is no muscular ingrowth, no muscle. So, remember, the septum transversum initially is in the neck region, in the cervical region. Within the region, that septum transversum is invaded by the cervical somites, the cervical myotomes. So failure of invasion of the cervical, failure of these cervical somites to invade the septum transversum means that part of the diaphragm will be amuscular, will be non-muscular. Part of the diaphragm won't have muscle. Instead of a muscle, you'll have a membrane, a thin, delicate membrane, and that is the eventration of the diaphragm. In a hernia, there is a defect. And what are the common types of diaphragmatic hernias? What are the 2 most common types of congenital diaphragmatic hernias? Which are the 2 most common types? Because this one you'll be asked. Very good, Mesha Kochanda, very good. 1, the Bosch-Dallek hernia. Now, the Bosch-Dallek hernia occurs in the left posterolateral part of the diaphragm, as shown here. Remember, this is the right side, this is the left side, as shown here. You can see it's occurring in the left part. That's a Bosch-Dallek hernia. Remember the reason I've emphasized on the left. Remember what we said. The left pleuroperitoneal canal closes later. Okay? So there is chances that failure of closure, if you compare the 2, the left pleuroperitoneal canal, in most cases, fails to close. Okay? The right one will have already closed. Okay? What about the other one? Very good. Mogagni hernia. Okay, so this one is a retrosternal. Retrosternal. It's a retrosternal hernia. It's a hernia just behind the sternum. A retrosternal hernia. Okay, it's an anterior hernia. Okay, retrosternal or parasternal. Just just behind or on either side of the sternum. That's a, a Mogagni hernia through the foramen of Mogagni. Now we will trick you in your exam. We will ask you name the structures which pass through the foramen of Mogagni. By the way, can you tell me what structures pass through the foramen of Mogagni? Can you tell me what structures pass through the foramen of Mogagni? Aha, very good. The superior epigastric vessels. Very good, Victor. I can see, hey, you mean I already have a junior guy here. Monyeri Junior, you guys. Okay, so we have a that type of a hernia, the hiatal hernia. Okay, that is good, eh? Hiatal hernia, very good. Now, yeah, you see, I levator palatini, tensor palatini, eustachian tube. Those structures, do they pass through the foramen of Mogagni? Do they? Or is it the sinus of Mogagni? You see, I got them even without getting there. That is usually the trick question in your exam. Eh? Sinus of Mogagni versus foramen of Mogagni. Foramen, you have superior epigastric vessels. Everything else, these other things, eustachian tube, levator palatini, those ones are in the sinus of Mogagni, as Emmanuel has told us. Very good, Emmanuel. Very good. Please note the difference. Yes, and I'm done with the diaphragm. Yeah, now maneno. I can give you how many minutes do you want we do development of the heart? This one we might take an hour. How many minutes? 5? Okay, yes, thank you, Doreen. 5 minutes. So please be back by 9:43. 9:43. In fact, Victor is saying no break. We continue, eh? Okay, let us give us a break because I also need some break to go and drink some water. Eh? Yes, if you have questions, please put the questions in the chat box right now. Um, um, your colleagues can answer. I'll also answer others. Eh? Please be back here by 9:43. I'll start with the anatomy of the heart, even if so that even if you don't come by 9:43, you just find you are recapping the anatomy, which you know, I presume. Okay, I hope you are back and you can hear me. Am I audible? Are you there? Are you back, guys? You have gone to sleep? No sleeping. It's very early. No sleeping. Very early right now. Very early. Hey, kwani how old am I, guys? You are calling me mzee. How old am I? Yes, I'm older than. I'm not that old as you might think. But maybe I am old, eh? Okay, thank you for confirming. Okay, we continue. Thomas, you think I'm 27 years? 27 is that's very, 27 years. I was 27 years, 1963. Okay, we continue, eh? So, in the development of the heart, as you can see, I've even taken time to break down the development of the heart. I think in my experience in anatomy for the years I've been doing anatomy, I think the heart is one of those organs which even myself, when I read those complex anatomy books to really understand how the heart is formed, I still have problems to this day to fully grasp, because it's a I believe the heart is one of the most magnificent organs in our body. Together with the brain, those two, the development of those two, if you were to consider the core embryology, that deep embryology, it's a lot of events. In fact, most of the events are still unaccounted for. Okay, so development of the heart. So from my view, I will break it to as simple as I can, as simple as it gets, because I don't think you need those BSc or MSc anatomy details. You do not need them. You just don't need the basic details. If a patient comes to you, they have a hole in the heart, and you'll be able to explain why that hole is there using layman term language. Yeah? So that is just, you just need basic anatomy to understand that. Eh? But if you want to do a research, you might need to go to the advanced anatomy. Eh? So I'll just recap the anatomy, the gross anatomy. Then we shall discuss how the heart tube is formed, the parts of it, how the atria are formed, how the ventricles are formed, and the cardiac septation will be done in less than an hour. Review of the anatomy of the heart, inferior vena cava there, with its valve, the valve of inferior vena cava there, or the eustachian valve, coronary sinus ostium or opening with its valve, the Webertian valve. Then the right atrium, ideally you should see the fossa ovalis, and the limbus, okay, or the annulus ovalis. Then that's superior vena cava. So this is the smooth part of the right atrium. So the smooth posterior wall. You have a smooth posterior wall and a rough anterior wall. Okay, so you need to remember this stuff. Eh? Also, for the left atrium, you have a smooth posterior part and a rough anterior part of the left auricle. And then you have the ventricles, which have a rough inflow parts. So both of them rough inflow parts, what are known as trabeculae rani, and the smooth outflow parts. For the right side, the outflow part is there, the conus arteriosus, or the inferior, and the left part is the aortic vestibule. So you need to remember the parts of the atria and the ventricle, because now this is what we'll be discussing. Now that is just the basic anatomy. That one is an easy one. Now, how does the heart tube form? I'll keep it as basic as it can get, because formation of the heart tube, actually, if we were to talk formation of the heart tube alone, it can even take 2 hours, including the molecules which are involved here. So that is now the anatomy which I expect those guys who are doing BSc right now to know. But for you, don't just tell me where it is, where is the heart tube located, how is it formed? So within the splanchnic mesoderm, the underlying endoderm, this endoderm, okay, the underlying endoderm induces the overlying splanchnic mesoderm in an area known as the cardiogenic area. So we have an area known as cardiogenic area, and as the name suggests, this area is the one which will give rise to the future heart. So the splanchnic mesoderm in this cardiogenic area is induced by the underlying endoderm. This is endoderm, to form a cluster of cells, what are known as angioblasts. Okay, so angioblasts are formed. These angioblasts fuse to form what are known as angioblastic cords. Angioblastic cords. Okay, then these cords canalize. They canalize to form the heart tube. Okay, the heart tube. So initially, you have two heart tubes, but then during lateral folding, the two heart tube approximate to the center part. They approximate to the central part and they fuse to form one single heart tube. So I have already described the formation of the heart tube. So angiogenesis, yes, that process of angiogenesis, okay? Formation of angioblast, which fuse to form angioblastic cords, which canalize to give rise to the heart tubes within the cardiogenic area, or it can also be known as the heart field. Heart field. Okay, so you can see initially there are two of them, but due to lateral folding, they fuse to form a single heart tube. So you have already formed the heart tube. But now, the other detail is that this heart tube is formed just dorsal, just not let me not use dorsal, just caudal to the septum transversum in the most cranial part. In the most cranial part of the embryo, that is where the cardiogenic field is at initially. But due to longitudinal folding now, especially this head fold, that cardiogenic field, the heart tube moves inferiorly, okay? It moves inferiorly, and now this was the brain. This is the future brain. I want you to see the brain. The heart will be there. That's the heart. The heart should be there. But due to this head fold, you can see now that the brain comes to lie cranial or cephalic now to the heart. And also the septum transversum initially is cranial to the heart. But due to this folding, the cephalocaudal folding, the longitudinal folding, that septum transversum now comes to lie caudal to the heart. And as you know, that septum transversum will give rise to the central tendon. And from the anatomy, gross anatomy, you know that the heart sits on the central tendon of the diaphragm. Okay, so it forms the heart tube, and this heart tube initially is a tube, just a tube. But with time, it acquires dilatations. And now these dilatations are the ones which are named. So what are the parts of this heart tube? So the heart tube has the following parts. It has a sinus venosus, so that's the first dilatation. The second dilatation is the primitive atrium. The third dilatation is the primitive ventricle. Okay, so that. Then we have the fourth dilatation is known as the bulbus cordis. Okay, the bulbus cordis. Now, let us start. The sinus venosus, this is the venous end. Venous end. This here, the bulbus cordis, is the arterial end, especially what is known as truncus arteriosus. That is the arterial end. Now, blood will come in through the venous end, move like that, and go to the aortic sac. So blood will be moving in that direction. So the aortic sac connects to this truncus arteriosus. Now, Oh, Moai Boston. What am I pardoning? Moai Boston. What am I pardoning? Sorry, I had not seen that message. What am I pardoning here? Boston. What am I pardoning? Okay, you have been assisted. Thank you. Okay. Now, as I was saying, we have a venous end and an arterial end. Blood enters through the venous end, goes towards the arterial end. When I was a young boy, many years ago, I used to go to the farm and let me not call it a farm, it's a shamba. Big difference. To go to the shamba and where I'm from, we have very many earthworms. And the anatomy of the earthworm, I think that is what first intrigued me. The anatomy of an earthworm, because if you look at an earthworm, it usually has a tubular heart. Its heart is a heart tube, like just the same as this one here. I don't, if you come across earthworms, just go and check. I don't know how I came about that, but I can still remember that its heart is tubular. It has a tubular heart, just like this one illustrated here. Okay, but you can see someone is saying Java. Thomas, relax, one. Now, the earthworm has a heart tube. Once upon a time, your heart and that of an earthworm is the heart tube and the heart of an earthworm, they're almost similar. So that tells you something about evolution, okay? That tells you something about evolution. That our hearts, there was a stage during development that our heart and that of an earthworm was the same. But now, for the human heart, it does not stop at this point. It has to develop more and more. Okay, let me plug in my PC. Okay, what is happening now? Okay, so Rosa, the heart develops from the cardiogenic area. Yes, the heart develops from the cardiogenic area. Septum transversum gives rise to the central tendon of the diaphragm, the central tendon of the diaphragm. If you come across other ones, this is funny. Dora, you have no intentions of going to the shamba? Yeah, you might come across earthworms for those who own shambas. I know this might sound weird for those guys from urban areas. Where will you find earthworms in Nairobi? Now, those are the dilatations. We have discussed the dilatations. Now, the sinus venosus is the venous end. It is receiving venous blood. So it is connected to, the sinus venosus has two horns, a right horn and a left horn. Each horn receives three vessels. Each horn receives three vessels, what are known as common cardinal vein, umbilical vein, and vitelline vein. Now, the common cardinal vein is formed by the union of anterior cardinal vein with posterior cardinal vein. Anterior cardinal vein drains the head and neck structures, the future head and neck structures. Posterior cardinal vein drains the lower limbs and the trunk. And they unite to form the common cardinal vein. Now, the umbilical vein drains the placenta. That is obvious. And then the vitelline vein, on the other hand, drains the umbilical vesicle. The umbilical vesicle is drained by the vitelline vein. So these structures drain into the horns. So both on the right side and on the left. You can also see the left side has the three. But what you need to understand is that the left, these three vessels, the common cardinal vein, the vitelline vein, and the umbilical vein, those of the left side just disappear, except for the left umbilical vein. okay, except for that guy. Okay, so those ones just disappear together with the left horn. So the left horn disappears, involutes, but the only remnant of the left horn is the coronary sinus. But I have seen some articles which also include the oblique vein of Marshall. Okay, so I've seen some articles including that recently, so I don't know the authenticity of that, but they are including that. So coronary sinus and the oblique vein of Marshall, those are derivatives from the left horn of sinus venosus. What about the right horn? The right horn of sinus venosus is incorporated into the right atrium and forms the sinus venarum. Sinus venarum. Now, the right common cardinal vein forms part of the superior vena cava, and the right vitelline vein forms part of the inferior vena cava. Okay, so you need those. Oof, what happened again? Okay, I think it's now back. It's now back. Now, you need to remember that. You need to remember that. Then, as you have been reminded here, umbilical vein, ligamentum teres. Okay, yes, ligamentum teres. Now, you can see that the sinus venosus, remember, sinus venosus has parts, it has a body and the horns, okay? Now, the body of the sinus venosus communicates with the atrium. So this communication is what is referred to as sinoatrial orifice. Sinoatrial orifice, and we shall discuss the sinoatrial orifice. Then the atrium here, the primitive atrium, gives rise to the rough parts of both right and left atrium. So we have already discussed, in fact, we have already discussed development of the right atrium. The smooth posterior wall is derived from the right horn of sinus venosus. The rough anterior wall is derived from the primitive atrium. You have already developed the right atrium. What about the left atrium? The rough anterior wall is derived from the primitive atrium. The smooth posterior wall, I'll show you where it comes from. Now, the atrium communicates with the ventricle via the atrioventricular canal. Remember, this atrioventricular canal has to be partitioned. Initially, it is just one channel, but remember, the atria are two, left, right. The ventricle are also two, left, right. So this channel has also to be partitioned so that the right atrium communicates just the right ventricle. The left atrium just communicates with the left ventricle. So this atrioventricular canal has to be partitioned, and that is what constitutes the atrioventricular septation. Now, the left ventricle here, the primitive ventricle here gives rise to the primitive, the primitive left ventricle, no. The primitive ventricle gives rise to the trabeculated part, that rough part of left ventricle. So it's just called primitive left ventricle because it gives rise to the rough part, the rough inflow part, that rough inflow part of the inflow part of the left ventricle. Hey guys, skizeni bwana. Don't just bother with the chat box. Where skiza these stories? Now, so the primitive ventricle gives rise to the trabeculated part of the left ventricle. What about the bulbus cordis? The bulbus cordis has three parts: a distal third, a middle third, and a proximal third. The proximal third of the bulbus cordis is the one which gives rise to the trabeculated part of the right ventricle. So the trabeculated part of the right and the left ventricle have different origin. That of the left ventricle comes from the primitive ventricle, and the proximal 1/3 of bulbus cordis gives rise to the primitive right ventricle. Shika hiyo. Let me see what. Okay, I think. Okay, let me repeat. The primitive ventricle here gives rise to the trabeculated part of left ventricle, whereas the proximal one-third of the bulbous cordis, this proximal one-third in whatever that color is, gives rise to the trabeculated part of the right ventricle. Now, the middle one-third of the bulbous cordis is known as the conus cordis, gives rise to the outflow tracts. So the smooth parts of both right and left ventricle. So on the right side, it will give rise to the conus cariosus or the infundibulum. On the left, it will give rise to the aortic vestibule. And then the distal one-third of the bulbous cordis, which is known as the truncus arteriosus, is the one which gives rise to the ascending aorta and the pulmonary trunk. Okay? So that is how if you understand this image just the way it is, even if they point, you know what will happen in your marathon end of year, they'll be pointing, say, they'll be pointing the aortic vestibule, and the question would be, the structure pointed is a derivative of what? So you need to remember aortic vestibule is a derivative from the conus cordis, okay? The conus cordis, because it's part of the outflow tract. So they can ask you name, then B, the derivative of what? Most of the questions from the heart specimens are usually asked like that, because they can also point, say, the ventricle, the trabeculated parts, and then they ask you it's a derivative of what. So if they point the right side, you have to tell them it's a derivative of the proximal one-third of the bulbous cordis. If they do the same on the left, you have to say it's a derivative of the primitive ventricle. Okay, so that one will be tested one way or another. So this is the heart tube, but our heart does not look like that. So for this heart tube to form the adult heart, which you and I know, you need this process known as cardiac looping. So where the heart folds on itself. So how does cardiac looping occur? Now in cardiac looping, it's very simple. What you need to remember is that the venous end, this is the venous end, the sinus venosus and the primitive atrium. This is the venous end. The venous end moves upwards cranially and posterior. So it moves upwards and posterior, whereas the arterial end, that is the outflow tracts, that is the bulbous cordis, and the primitive ventricle. These ones move downwards and anterior. So as you can see illustrated here, you can see that in, what color is that? That one. That is the bulbous cordis. And you can see that the proximal one-third, this proximal one-third here, will actually form part of the right ventricle. This primitive ventricle here is this one, which will form part of the left ventricle. It's starting to take the shape of the heart, which you know. And then this is which will form now the outflow tract, this the conus cordis, the truncus arteriosus. And then whatever was down here has moved upwards and posterior. And so it has moved posterior. That is why the base of the heart is formed by the atria. The base of the heart is formed by the atria. As you might have seen even in the labs, the atria are somehow situated posterior, the ventricles are anterior, okay? And that is thanks to cardiac looping, And as you can see, truncus arteriosus there, conus cordis, proximal one-third. This proximal one-third of the bulbous cordis is what will give rise to the right ventricle, the trabeculated part. The primitive ventricle will give rise to the trabeculated part of left ventricle. Conus cordis will give rise to the outflow tracts. So on the right side, it will give rise to the conus arteriosus or the infundibulum. On the left, will give rise to the aortic vestibule. Truncus arteriosus will give rise to the aorta and the pulmonary trunk. And as you can see, the primitive atrium is back there, which will now undergo partitioning so that this becomes the left atrium and this becomes the right atrium. That's how cardiac looping takes place. Now, initially you have one atria as shown here, one big chamber. Let me use now another. It's just one big chamber. But this primitive atrium has to be divided, okay, has to be divided to form now the right and the left atria. How does this take place? So interatrial septation, you form two septi. The first septum to form is what is known as septum primum. It's the premier septum. It's the first septum. It's the premier septum. So that septum, as you can see, it is sickle-shaped. You can see sickle-shaped. So the lower end does not. So this part, this lower part, this is what is known as endocardial cushion. We discuss how the endocardial cushion is formed shortly. So the septum primum grows from the roof. So I want you to think in terms of that room you are in. Think it's like a curtain which is coming from the ceiling downwards. So that septum primum comes from the roof towards the floor, but the lower end is sickle-shaped. And for that reason, blood within the right atrium can go to the left atrium via now that primary foramen, what is known as foramen primum or foramen primum, okay, the premier foramen. But as this septum primum elongates further, okay, as it elongates further, now the sickle, now the foramen primum, the foramen primum, 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 whatever, as the foramen primum is being obliterated, as you can see here, initially it is bigger in size, but as the septum primum is increasing, is growing in size, that foramen is decreasing in size. So what happens is that in the upper part of the septum primum, those cells undergo apoptosis and they form now the foramen secundum. So foramen secundum is an opening within the septum primum. Let me repeat that. Foramen secundum, the secondary foramen, is an opening through this is still septum primum. This is still septum primum. Now, what happens next? Septum secundum grows just to the right side, of the foramen secundum. Another septum starts to grow from the roof still downwards, but as it grows, it does not touch the floor. So it just grows, say, halfway, okay? Just half the length, okay? Half the length, the supero-inferior length, the craniocaudal length of the atria. So it just reaches halfway, okay? So if you view it, I want you to view, how would you see this? How would you see this if from another view? So from another view, it might be seen as this image as shown here, simplified. That's the right atrium, that's the left atrium. So this here, you can see this is septum primum. That's the septum primum with this, that is the foramen secundum there. Just to the right side, that's the septum secundum, okay? So now this resultant foramen is now the foramen ovale. So that foramen is the foramen ovale, okay? So this septum primum here acts as a valve. It acts as a valve. It only allows blood to come from the right to the left atrium. Okay, why? Because if pressures on the left atrium are increased, so let me erase this. So as shown by the arrow, that's how the blood flow will occur. Okay, but now what happens is that what happens after birth, or what happens, yes, after birth now, after birth, pressures within the left atrium will go up. Pressures within the left atrium will increase. So because of that increase of pressure within the left atrium and a decrease of pressure in the right side, this part of the septum primum will be forced to move in that direction. Okay, it will flap. So it is closed due to high pressures of the left atrium. Okay, so it's a flap valve. Okay, it's a valve. Okay, which during birth closes. So that is the physiological closure of foramen ovale. So physiological closure of foramen ovale occurs at birth. What about the anatomical closure in the chart box? When does the anatomical closure of the foramen ovale take place? When? When does the anatomical closure of foramen ovale take place, guys? Physiological closure occurs just after birth, because after birth, the pressures of the left side increase and cause this flap of septum primum to obliterate the foramen. 6 months, 3 months, 1 year. So you can see you have very many answers. You have very many answers. So at what period does it close? At what time age? At what time? Is it 1 year? Is it 3 months? Is it 6 months? You and then you research before first birthday. Yeah, okay, Nicolette, that is a very good answer, because by saying before the first birthday, you are giving yourself the allowance from the time they were born until they celebrate the first birthday. Yes, it occurs somewhere along there. So it's within the first year, but at what specific timeline? Is it exactly at 1 year? Is it at 6 months? Is it at 3 months? Eh? Previous slide. You want the previous slide? Yes, there's the previous slide. Remember what I've said. Foramen secundum is an opening in the septum primum. Okay? In the septum primum. It is formed by apoptosis of the cells of the septum primum, as shown here. Those cells, you can see them, they are dying. They live out there. Now they form the foramen secundum. So, sinus venosus forms the sinus venarum. Yes, yes. I thought secundum is just another opening by itself on the right of primum. No. Foramen secundum, I repeat again, it's an opening in the septum primum. Okay, but septum secundum grows. It grows on the right side of foramen secundum. What did he say forms sinus venarum? Sinus venarum is all formed by the right horn of sinus venosus. Conus arteriosus is the smooth outflow part of both ventricles. Ooh, Andel Budok. Hey, this is not the Andel Budok we know. No. Andel. Conus arteriosus is on the right side. On the left side is known as the aortic vestibule. Why? Andel Budok. Name of the foramen at septum secundum. Now, the septum secundum does not have a foramen. Okay, so let me go back here. So already this foramen, this one here, let me use another ink. This foramen here in the septum primum, that one, that's the foramen secundum, FS, foramen secundum. So septum secundum just grows on the right side, but it does not reach the endocardial cushion. This is the endocardial cushion, EC. So it does not reach. So it just now forms that complex foramen formed there. That is now the foramen ovale. So think about it. After birth, remember what I've said. This flap of septum primum will be pushed to the right. So once it is pushed to the right, let me erase everything which I've drawn here. So during birth, because the pressures of the left side increase, this flap of septum primum is pushed to the right. So, and it adheres to the septum secundum. So if you view it on the right side, you'll see a depression. With an elevation. And now that is the fossa ovalis and the limbus. And the fossa ovalis, the floor of the fossa ovalis is actually a derivative of this. Because from this view, if you put your eye there in the right atrium, the floor will be seeing this. So the floor of the fossa ovalis is a remnant of the septum primum. But the limbus, you'll be seeing this edge. You'll be seeing this edge. So you'll be seeing the lower edge, the lower free edge of septum secundum, and that is what forms the limbus. So the limbus is formed by the lower free edge of septum secundum. Hiyo mumeelewa? As that one, have you understood that one? Banu Prakash, why are you kindly? Where do the left atrium come from? I'm discussing it. Relax, 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 Mesha Kochanda. We are still to discuss it. The drawing, explain it. Okay. Let me erase the ink again. So remember what you have said. You have a right atrium and a left atrium. Initially, it's just one atrium, but you need to partition it. So what happens initially is that the septum primum grows from the roof. So this is the roof, this is the floor. At the floor, you have what is known as endocardial cushion. I'll tell you where the endocardial cushion comes from. So initially, from the roof, the septum primum will grow downward, will grow downward like that. So initially, it will grow downward like that. So initially, the only foramen which will be here will be just at the bottom of the septum primum, and that will be the foramen primum. But then, as this septum primum grows, that foramen primum is obliterated. It is closed out. And what happens is that cells of the upper part, cells of this upper part of the septum primum actually undergo apoptosis. They die off, and now you form a foramen secundum. Okay, a foramen secundum. So I've already formed that. Then to the right side of the foramen secundum, another septum starts to grow. This time it grows from the roof, but it does not touch the floor. It just grows halfway that length, and that's the septum secundum. So this forms a channel there, which is now the foramen ovale, But now the question is, what would happen after birth? After birth, the pressures of the left side increase. If they increase, this part of the septum primum is pushed to the right side. And by being pushed to the right side, it abuts to the septum secundum. Okay, it abuts to the septum secundum. And if you were to view, if that is your eye there, if you were to view this from the right atrium, you'd see a depression with an elevation. So you'd see the fossa ovalis. The fossa ovalis, this depression, you'd see it here. Okay, and then this elevation at the edge is actually this. You are seeing the lower free edge of the septum secundum, which is now forms the limbus or the annulus ovalis. I think I have tried to explain that. Yes, I think I have explained also the flow of fossa ovalis. So it's a derivative of the septum primum, and the limbus is actually a derivative of the septum secundum. Sawa, hiyo shikeni. Now, please pardon on conus arteriosus. Conus arteriosus is the conus arteriosus is the other name of the infundibulum. Conus arteriosus is a derivative of conus cordis. Conus cordis is what gives us conus arteriosus on the right side and aortic vestibule on the left side. Conus arteriosus is the same as infundibulum. Sawa. Conus arteriosus and conus cordis are not the same thing. They are not the same thing. Conus arteriosus is a derivative of conus cordis on the right side. On the left side, it's aortic vestibule. I think I have emphasized on that. Let us discuss still the part of the so the smooth posterior part of the right atrium comes from the right horn of sinus venosus to form the sinus venarum. The right horn of sinus venosus will also give rise to the coronary the coronary sinus, also the oblique vein of Marshall, and also remember what he said, superior vena cava comes from the common cardinal vein, inferior vena cava comes from your infiltrate vein. Oh, what did I say? No, coronary sinus and oblique vein of Marshall actually come from the left horn of sinus venosus, not the right. Sorry for that. The left horn of sinus venosus is what gives us coronary sinus and the oblique vein of Marshall. I need to confirm this because I've seen it in some articles, but not in any of the approved anatomical text. But for now, the one which I'm sure is coronary sinus. So just write coronary sinus. If asked, name one derivative of the left horn of sinus venosus. Sasa najua nyote mtaandika oblique vein. Please, hebu kwanza muandike coronary sinus as I confirm. Okay. What of SA node? Now, SA node is simply those cardiomyocytes at the point where the superior vena cava meets with the right atrium. At that point, those cardiomyocytes become differentiated and they depolarize at a faster rate and they form the SA node. Okay, so SA node is simply a modification of the cardiomyocytes. Nothing, it does not come from any neural cells. It's simply, remember, the conduction system of the heart are simply specialized cardiomyocytes. They are not nerve cells. They are not nerve cells. Yes, it is found in the superior part of crista terminalis. Yes, actually where the sulcus terminalis meets with the superior vena cava, that is where you find the SA node. Now, beneath the left atrium. So remember, the left atrium, as Ochanda was asking, the anterior part, the rough anterior part, comes from the primitive atrium. That one is known. But now the smooth posterior part is formed from the pulmonary vein. Initially, the four pulmonary veins, you can see the four of them. Initially, you just had one pulmonary vein. All the four, remember you have two pulmonary veins from each lung, a superior and an inferior. So let's say that's the right superior and inferior. This is the left superior and inferior pulmonary veins. The four of them initially, the four of them fused to form a single pulmonary vein. But what happens during development, this pulmonary vein, the trunk, that pulmonary vein, the common pulmonary vein, is absorbed. It is taken up. Okay? The left atrium absorbs it. It is taken up by the left atrium, and actually it now forms the smooth part. So the smooth posterior wall is a derivative from the pulmonary vein. So you can see it has been taken up until to the level where now, instead of the four pulmonary veins draining into a single vein, which now eventually drains to the heart, now the four pulmonary veins come in as separate entities to the left atrium because the pulmonary vein, the single pulmonary vein, was absorbed into the left atrium. Ochanda, are you now okay with the formation of the left atrium? Pardon. Okay. Remember, the atria has two parts, a smooth part and a rough part. So the smooth part, the smooth posterior part, comes from the absorption of the single pulmonary vein, the single pulmonary vein. Now, this pulmonary vein here, it was a single pulmonary vein in that the tributaries, it was receiving tributaries now from the superior and inferior pulmonary veins. From your gross anatomy, you know that you have four pulmonary veins opening into the left atrium, right? But that was not the case initially. Initially, the four pulmonary veins would drain into a common vein, which was known as the single pulmonary vein, which would now drain to the left atrium. But what happened during development, that single pulmonary vein, that common channel to which the four pulmonary veins, which now are the four pulmonary veins, were draining to. Now I'm confusing myself. Let me repeat that. Initially, you had a single pulmonary vein, which would receive the four pulmonary veins. But as the atrial development continues, the left atrial development continues, that single pulmonary vein is taken up. It is taken up by the left atrium. It is incorporated into the left atrium, and it now forms the smooth part. Okay, it now forms the smooth part of the left atrium, which you know. How can the single pulmonary vein drain to the left atrium if the left atrium is what it is forming? It is draining to the primitive left atrium. It is draining to the primitive left atrium. This primitive left atrium is what we now form the anterior wall. So this single pulmonary vein, as it is incorporated, it is now forms the posterior smooth wall. Okay, I hope I have explained that. Full stop. The same as the oblique sinus is due to absorption of oblique sinus. Smooth part of left atrium from pulmonary vein. Yes, from the single pulmonary vein. Yes, from the single pulmonary vein. Please, we will ask you. We will point to the smooth part of the left atrium so that you tell us the right horn of sinus venosus, and I mark it wrong. Yes, so the rough part. Yes, for both atria, the rough parts come from the primitive atrium. But the smooth part for the right side comes from the right horn of sinus venosus. On the left side, it comes from the single pulmonary vein. Yeah, I think that is it. I don't think I'll teach this. Acha itu niruke. Yeah, this will not add value. Hii labda ya PSC. Nitaambia kina BSc. Yeah, so I've summarized. Yes, ndio hiyo summary. Sasa everything which I've been talking, if you have been asleep, wake up and just see this slide and go back to sleep. So the right atrium, the rough anterior wall from the primitive atrium, the smooth posterior wall from the right horn of sinus venosus. Left atrium, the rough anterior wall from the primitive atrium, the smooth posterior wall from the absorption of the pulmonary vein. Yo. Yes, I can see BiteMed has explained that. Very good. Oh, nimeona you have known where I've got this slide from BiteMed. Yes, we watched this video when we were in first year. Or rather when we were doing BSc. So it's a very good video and decided to snatch the slides. Now, how does atrioventricular partitioning occur? Remember, initially, let me try to draw that. So you have just an atrium and a ventricle. So that's the primitive atrium, that's the primitive ventricle. So you have the atrioventricular canal there. So this canal has to be, remember, the atria is divided into two. So you have a right atrium and a left atrium. Also, the ventricle will be divided into two, a right ventricle and a left ventricle. So you want also this partitioning to take place in that canal, so that you don't want contents of the right atrium to go to the left ventricle. You don't want that. So how does this occur? So at the atrioventricular canal, you have mesenchymal proliferation of the mesenchyme. So the mesenchyme around that, surrounding that orifice or canal proliferates to form what are known as endocardial cushions. One is superior and an inferior endocardial cushions. Then these endocardial cushions just fuse in the midline. just like that. And you have already carried out atrioventricular septation. So this would be the right orifice. So the right atrioventricular orifice and the left atrioventricular orifice. Now, next what happens is you need to form the tricuspid valve on the right and bicuspid valve on the left. So another thing happens is that on the right side, this endoderm, remember this is still not endoderm, endocardium. This endocardium on the right side, it starts to proliferate, okay? It starts to proliferate to form what are known as primitive valves, which now eventually give rise to the valves. So the valves, the take-home message is also that the valves also come from the endocardial cushions, okay? Endocardial cushions give rise to the atrioventricular valves, that is tricuspid on the right and bicuspid on the left. If asked the origin of the interatrial septum, what do you say the closure of? No. Interatrial septum will come now from the septum secundum and septum primum. That's the interatrial septum. That's the origin. Okay, that is simply a repetition. Allow me to go fast because of time. Cardiac looping. Yeah, we had seen this. Okay, let me repeat. Let me now focus on this final image here. So, truncus arteriosus, conus cordis, proximal 1/3 of bulbus cordis. Now, this is what will give rise to the trabeculated part of right ventricle. Primitive ventricle will give rise to the trabeculated part of the left ventricle. Now, I want us to imagine if you cut through here and see the inside. So remember what we said. The ventricles are anterior, the atria are posterior, shown here. Atria are posterior. So what you'd see, if you cut through there, you'd see something like this. You'd see something like this. You have cut through there. So remember the ventricles are behind the right, not the ventricles, rather the atria, the right atrium there, the left atrium. So here you can see there, that's the atrioventricular canal, and you can see it has been partitioned by the superior and inferior endocardial cushions. You can see, so it has been partitioned like that. So you need to partition the ventricles. You need to carry out what is known as interventricular septation. So interventricular septation, if you can remember the interventricular septum, it has two parts. It has a muscular part in the lower part and a membranous part in the upper part. Now, the muscular part is simply formed by an outpouching, an upward growth of the mesenchyme of the both ventricles. Okay, so we have a left ventricle there and a right ventricle. So the mesenchyme between those two ventricles at the midline, it starts to proliferate upwards. And that one will form the muscular part of the interventricular septum. What about the membranous part? Now, you see this endocardial cushion in green? I want you to imagine, so you can see, so this is still left ventricle. So this is an opening. Let me use another ink, because now this is still an opening. That is still an opening. So you need to seal that gap. What happens is that in green now is the endocardial cushion, which separated the atrioventricular canal. What happens is that it proliferates. So it proliferates and actually, so it proliferates to fill that gap. And it forms the membranous part of the interventricular septum. But also the membranous part of the interventricular septum will be formed by the bulbaridges, which are part of the conotruncal septum, okay? So the membranous part of the interventricular septum has two sources. One, the endocardial cushions. Two, the bulbaridges or the conotruncal septum or the aorticopulmonary septum. As the name suggests, the septum between the aorta and the pulmonary trunk. Okay, so those are what forms the membranous parts. Yeah, so that is how interventricular septation occurs. Let us finally discuss the aorticopulmonary septation. Now, conotruncal septation stroke aorticopulmonary septation is the same. This one is a special one. Even if you don't remember the other ones, try to find some RAM in your mind to fix this. Now, as the name suggests, conotruncal septation. You are dividing the conus cordis and the truncus arteriosus. Okay, so this septation, for you to do that, for you to okay, let me put my phone also charging. Okay. Now, for you to carry out septation of the conotruncal segment of the bulbous cordis, neurocrest cells are of critical importance. So one, neurocrest cells. And what is the function of these neurocrest cells? The neurocrest cells invade the conotruncal segment of the bulbous cordis to form truncal ridges in the truncus arteriosus and bulbar ridges in the conus cordis, okay? In the conus cordis. Now, what happens is that these ridges grow towards each other. Okay, so initially they are on the sides. So imagine they are on the side. So I will, so imagine if you cut at that level, and at that level. So 1, 2, 3. So 1, 2, 3. 1, 2, 3. Let me use now different colors. So initially you see that, but when you go to 2, it comes there. And when you go to 3, it comes there. Interesting stuff. In 1, the blue one was there. It comes there and it goes there. So what is happening here? So I want you to stack this on top of each other. Let me draw 2 below 1 and 3 below 2. So let me draw them like this. I know it will take a lot of time. It will take a lot of time, but let me I want you to imagine these dreams in 3D. 3D. So you did 3D maths in Alliance. So lazima mjue hii vitu. Kama Alliance amu kufunzwa 3D. Okay, now I want you to imagine how they fuse. So initially it is there, it fuses there, then it comes there. So what is the take-home message here? Okay, let me erase that. What is the take-home message? Is that this septation occurs in a spiral fashion. What I'm trying to show here, it occurs in a spiral fashion, as shown here. The aorticopulmonary septum, you can see it's a spiral fashion. It's a spiral fashion. So that, remember, the aorta comes from the left ventricle, but you can see the aorta is to the right here. Then pulmonary trunk comes from the right ventricle, but it's to the left here. What is happening? What is happening? Because of this spiral aorticopulmonary septation. So conotruncal septation occurs in a spiral fashion. That is key, because now I think this is the final stretch, because if you understand that conotruncal septation, it occurs, I need you to think about situations where things could go wrong. The first situation is, imagine these neurocrest cells decide, let us not invade that conotruncal segment of the bulbous cordis. Let us not. So if they do not invade the bulbous cordis, there'll be no conotruncal septation. 2, I want you to imagine a situation where they do invade, but they do not spiral. The aorticopulmonary septum does not occur in a spiral fashion. If it does not occur in a spiral fashion, the aorta will originate from the right ventricle. The pulmonary trunk will originate from the left ventricle. Okay? That situation I want you to think about, yes, it occurs in a spiral fashion, but it does not take place at the midline. So it is asymmetrical. One of the outflow tracts is bigger, the other one is smaller. Think about those three situations. And this explains why the pulmonary trunk, as you saw in the anatomy lab, why the pulmonary trunk crosses the aorta. So you can see the pulmonary trunk goes to the left, whereas the aorta goes to the right. Pardon. Yvonne Benson, what should I pardon? Everything regarding conotruncal septation or a specific part. Yvonne, everything regarding the neurocrest, okay? Oh, now I have low battery to my. Okay, let's hope they won't shut down. So, if my mic goes off, please let me know. The neurocrest cells usually invade the bulbous cordis. But which parts of the bulbous cordis? Remember, the bulbous cordis has three parts. They only invade the middle 1/3 and the distal 1/3, what is known as the cornus cordis, to form the bulbar ridges, and the truncus arteriosus to form the truncal ridges. Now, these ridges fuse in a spiral fashion. They fuse in a spiral fashion to form this spiral aorticopulmonary septum. And that spiral aorticopulmonary septum is the one responsible for the pulmonary trunk is to the left side, as shown here. You can see the pulmonary trunk is going to the left, but it is originating from the right ventricle. The aorta is going to the right, but it is originating from the left ventricle. In fact, when we did the surface anatomy of the thorax, the anterior chest wall, remember when I went to, there was a group on Tuesday, I can't remember which table. They were asking me, where do you auscultate for the valves? I can remember we discussed, we agreed that for you to auscultate, auscultation is the art of listening to body sounds using a stethoscope. So that is auscultation. So the place, where do you place the stethoscope if you want to listen for the aortic valve? You place it on the right second intercostal space. That is for aortic. But for pulmonary valve, you do the same on the left side, the left second intercostal space. Okay, it is from this understanding that the pulmonary trunk is directed to the left and the aorta to the right. I hope I have described the neurocrest cells, Yvonne. Yes, now the anomalies is what I was talking about. Now imagine if the neurocrest cells fail to invade the bulbous cordis. If they fail to invade the bulbous cordis, that means there'll be no conotruncal septation. That is obvious. 2, they invade the bulbous cordis, but the aorticopulmonary septum does not spiral. If it does not spiral, the pulmonary trunk will originate from the left ventricle, and the aorta will originate from the right ventricle. 3, the third situation is this. Yes, the aorticopulmonary septum spirals, but in this situation, it is not placed in the midline. So remember, you see this bulbous cordis, it's a tube. So this septation has to occur at the midline. So if it is displaced, this aorticopulmonary septum is displaced, that means one of the outflow tracts, in most cases, the aorta will be big in size. The pulmonary trunk will be small in size. Okay, so if that septation, even if it was spiral, but it did not occur at the midline, It means one of the outflow tracts, in major cases, the aorta is big in size, so it's overriding. And then the pulmonary trunk is small in size, it's stenotic. And then remember what we said, the other thing which we said, this aorticopulmonary septum forms part of the membranous part of the interventricular septum. So if it is displaced, if it is not in the middle, it won't fuse with the muscular part. It won't fuse with the muscular part of the interventricular septum. So you'll have a ventricular septal defect. Those features which I'm just describing here are features of which congenital anomaly. Those features which I've been describing. Very good, Rosa. Very good, very good. Tetralogy of Fallot. That is how tetralogy of Fallot comes about. Easy. The aorticopulmonary septum is not in the midline. If it is not in the midline, one of the outflow tracts becomes big in size, overriding aorta, at the expense of the other outflow tract, which is the pulmonary trunk, which becomes stenotic. And since the aorticopulmonary septum forms part of the membranous part of the interventricular septum, the membranous part of the interventricular septum is not formed. So you have a ventricular septal defect. Okay? And now the right ventricular hypertrophy comes later on. So right ventricular hypertrophy comes later on. Okay? So initially there are three, but at the time of detection, the right ventricle is now big in size. And the right ventricle hypertrophy is due to because the pulmonary trunk is stenotic, the right ventricle faces a lot of resistance. So as a compensatory mechanism to overcome this resistance of pumping blood to a stenotic pulmonary trunk, the right ventricle hypertrophies, becomes big in size. Becomes big in size. If you understand this table, you'll be done and dusted. Septation tumediscuss zote. Identify the anomaly. Identify the anomaly very fast tumaliza hii kitu. Rudisha table. Hai, kwani munachukua screenshots? Ndio hiyo table. But hapa kuna makosa kidogo tu. The primitive ventricle just gives rise to the trabeculated part of the left ventricle. The trabeculated part of the right ventricle comes from the proximal 1/3 of the bulbous cordis. Maybe you wacha tu niweke hapo proximal 1/3 of bulbous cordis. Yep. Remember, bulbous cordis has three parts: truncus arteriosus as the distal third, which now forms the aorta in the pulmonary trunk. The middle third, conus cordis, gives rise to the conus arteriosus on the right, which is also named as the infundibulum, and on the left, it gives rise to the aortic vestibule. Then the proximal 1/3 gives rise to the trabeculated part of the right ventricle. Please display a bit. Display what? Ama is the table. Victoria. Okay. Naona you are almost 100. 100 participants have dropped out. Nikumoto. Wana burnt. So name this anomaly. Tetralogy of Fallot. M. Mesha Kochanda, very good. Mesha Kochanda, unatuosha. Kidogo utuoshe, Mesha. Is this transposition of great arteries, guys? Kochanda, hapo umetuosha kidogo. I was even karibu hata mimi unioshe. I was to say very good until I noticed it's not. This is not transposition of great arteries. What is this, guys? ASD. Guys, check it. Brian, is this transposition? Is this transposition? I can see where the confusion is coming. They are just checking aorta, right ventricle, left ventricle, pulmonary artery. But that is okay. Aorta should be on the right, pulmonary artery to the left. Very good, Karen. Very good. Wonderful. Persistent truncus arteriosus, as you can see here. There is no partition in there. It's a common channel. That's there. Very good. Persistent truncus arteriosus. Wonderful. Next. Sasa hii, this one, it's the same. You can use A or B to identify it. Hii sasa. This one. So let me go back to this one. The persistent truncus arteriosus. Here, neurocrest cells did not invade. No invasion. Neurocrest, no invasion. So the neurocrest cells decided not to invade. And for that reason, there is no septation. No septation at all. This one, which anomaly have you said this is? Very good, Katrina and Bernice and M. Very good. That's now the transposition of the great arteries. Here you can see the left ventricle goes to the pulmonary artery, the pulmonary trunk. The right ventricle goes to the aorta. But you can see the septation is there. You can see the septum is there. So septation occurred, but in this case, it was non-spiral. So non-spiral conotruncal septation or aorticopulmonary septation is the cause of transposition of the great arteries. Very good. Yes. Next, this one. Which anomaly is this? Hii nayo inaweza watoa kidogo. Which anomaly is this? Very good, Joy. Yes, this is now TOF. Dextrocardia. Toa hiyo, toa. Zero back. Zero back trouble. No. It's TOF. This is TOF. Very good, as illustrated by Joy. Boot-shaped heart. You see this heart, kaa kiatu. And see, that boot-shaped heart, whenever you see that, just think of TOF. TOF, this is TOF. Boot-shaped heart, that is pathognomonic for TOF. TOF. So features of TOF, you had said them, ventricular septal defect, overriding aorta, pulmonary stenosis, right ventricular hypertrophy. Yeah, and that's the boot to show you the, whenever you see that, just think of TOF. Now, congenital heart anomalies are either divided to shunt or non-shunt. I'm finishing. I think this is the second last slide. Now, the shunt anomalies are either cyanotic or acyanotic. Cyanotic are those shunts which are also known as the right-left shunt. On the right side, you have the oxygenated blood. It's going to the oxygenated stream. So those are the cyanotic. So there'll be bluish discoloration of the skin and mucosa. They include tricuspid atresia. I don't have images for this. Please go find images of this. And as you might have seen from your exams, nowadays the department has decided to give you radiographic images. That is why even you see, I've used radiographic images for TGA, TOF, and PTA, the persistent truncus arteriosus. I used radiographic images. So the department wants you to understand. So find those images in the internet. Trust me, they get those images from the internet. They do not get them from patients. Most of them are from the internet. So cyanotic, go look at the image of tricuspid atresia, persistent truncus arteriosus you have seen. What was this? This should have been a TOF. TOF you have seen. This is total anomalous pulmonary venous return. Okay, find an image, either a cartoon or radiographic. Pulmonary atresia. Now, pulmonary atresia, the pulmonary trunk will be completely blocked off. As cyanotic, we have PDA, patent ductus arteriosus, ASD, VSD. Now, VSDs, I want to talk about this syndrome, Eisenmenger syndrome. In VSD, initially it is a cyanotic. Remember, if you have an opening in the interventricular septum, the pressures of the left side are always higher than those on the right. So initially, a VSD initially will have a left to right shunt, and this is a cyanotic. But with time, due to blood accumulating in the right ventricle will adapt to this volume overload, and the right ventricle will become hypertrophic. And eventually, the right ventricle might actually generate more pressures than the left. So if the right ventricle eventually produces more pressure than the left, now blood will now be moving from the right to the left. And now that will cause shunt reversal. So initially it is a cyanotic, but with time it might become cyanotic. So that shunt reversal is what is referred to as Eisenmenger syndrome. So please note that total anomalous pulmonary venous return is cyanotic, whereas the partial anomalous pulmonary venous return is a cyanotic. Then on to the non-shunt anomalies, 3 of them, coarctation of the aorta, find an image, dextrocardia, ectopia cordis. Dextro means right. There were those terms, if you are taught by organic chemistry, remember when you are talking about the chiral centers of those hydrocarbons, and you are saying the functional group might be dextro-rotated to form the D form or levo-rotated to form the L form. Dextro means that functional group has been rotated to the right to form the D form, whereas levo-rotated has been rotated to the left to form the L form. Okay? And remember, the human body, the sugars, we cleave the L forms, okay? If I give you D-glucose, you can't be able to cleave it. Go and check about that in biochemistry. Here's the same, dextro to the right, levo to the left. Yes, and water saturation. This one, I think this one, the people from my tables, I have emphasized this again and again and again. I think this, I'll leave you to go and discuss portal circulation for the sake of time. Portal circulation, and please remember the derivatives such as this: left umbilical vein, ligamentum teres; ductus venosum, ligamentum venosum; foramen of veil, fossa ovalis; ductus arteriosus, ligamentum arteriosum; umbilical arteries, medial umbilical ligaments. Yeah, those are the adult remnants. So, but a question, the questions which you can be asked in an essay, you'll be told a red blood cell is in the placenta. Trace its pathway until it comes back to the placenta. So you have to say it goes to the left umbilical vein, the ductus venosus. So this is a shunt, bypasses the hepatic circulation, connecting the umbilical vein to the inferior vena cava. Then from the inferior vena cava, from the right atrium to left atrium via foramen of veil, from the left atrium, left ventricle, aorta, then it will go back via the umbilical arteries which originate from the internal iliac arteries, okay? So be able to describe fetal circulation, please. Yeah, those are just the structures. These structures, we must have seen them this week in the anterior abdominal, on the inner side of the anterior abdominal, or you must have seen the median umbilical fold, which is a remnant of the uricus. The medial umbilical fold, these are remnant of the umbilical arteries. Retroumbilical fold are an elevation by the inferior epigastric vessels, epigastrics. Yeah, I think finally, the heart beats around 100,000 times a day. That is not important. What is important is to make these heartbeats count. I think I am done. Maswali, why not dextrocardia, apex to the right? No, 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 that was not to the right. Hey, this is the left side, eh? This is the right side. Sawa, sawa. Okay, if you have now questions, you can ask for chat box. Okay, let me see what questions. A question outside embryology. If asked, state the innervation of a gland like a cream module. For example, like parasympathetic. Do you state the nucleus or nerve or just you state everything? You start from the nucleus and tell us the function or component of that nucleus. Then tell us how these fibers will come from that, the superior salivary, no, the lacrimatory nucleus. How will those fibers from the lacrimatory nucleus trace their pathway until I hear they are in the lacrimal gland? Okay, trace their pathway until I hear they have entered the lacrimal gland. That is the way you get the marks. Also, if asked if the question is innervation, why just give parasympathetic? Also give us the sympathetic and also the sensory. Be blessed. Asanteni sana, hizi baraka nazipokea hizi baraka. Hata mimi ni unajua, there is a place where nimeband juzi. Yes, you are welcome, guys. I think we can end there. If you have no other questions, you always know my contacts. Kwa WhatsApp hapo, you always know it. Any questions, just reach out. I'll try to answer them. Hizi slides, wacha tuone kama nitawapatia. Because these slides have the other slides for also these slides have the other slides for the other systems. You guys are very lucky. Last year we did, you see what I displayed? Let me show you. Let me stop sharing. No. Why did I stop sharing? Yeah. You guys are very lucky, eh? Why? Because why am I saying this? Last year, that group which was here last year, we did something, I think, extraordinary. So last year, what we did is I decided to give these guys a field day. I remember we took like 5 hours. The session started around 7. In fact, it was around 6 hours. Yeah, because I remember we did everything. We did everything from respiratory system to the breast. We did everything in one sitting. And you can see the number of slides, 104. Right now, we have just tackled around 40 slides for that long. I remember that session was around 5-6 hours. Most of them dropped out. Nonetheless, I decided this year to make it easy for you. We divided it into 3 sessions. That way it becomes manageable. Umesema in the case of innovation. No. Hey, Abigail, see, I've said innovation, you put everything, both parasympathetic, sympathetic, and sensory. Kila kitu. Abigail, weka kila kitu. But if asked parasympathetic innovation, you now be specific. Just say the parasympathetic innovation. So the and not, so if asked that way, say the nucleus. But they usually specify, is it they want the nerve or the nucleus? They should specify that. But if it is an essay and ask the innovation, weka kila kitu. Any other question? I'm trying to see the previous charts. I think I have addressed everything. If I have not addressed anything, please let me know, eh? Abigail, unasema tu wa. What is wa? Wa in here? Bite med. Blood comes from the placenta, umbilical vein, some of it from most shunted by ductus venosa. Okay, then for diaphragm, diaphragm. Okay, descending to the descending, then common iliac, external iliac, umbilical, external iliac. Wewe bite med, external iliac. Toa. Umeharibu. Umeburnt just as you are about to finish. Not external iliac, internal iliac, eh? Toa hiyo. Okay. Okay, but good work, eh? So, I think I am done. Let me now see how I'll get my supper. Good night, guys, eh? We shall talk more. This recording will be sent to my YouTube channel so that you can watch it there and so that I can get some goodies. So, bye-bye. I am ending the meeting for all. Anyone who has a question before I end this meeting. Ati unakulaje sapa na uko na gastric juice? Emmanuel? Emmanuel, let me not say who said supper is food. By the way, I have a sister. I too have. What is happening? Why are you telling me you have a sister? Una burnt. You are burnt eh? Okay, I think there is nothing else which is sensical here. Wacha nimalize hii meeting kabla muanze kuniuliza kama mimi ni Gen Z. This meeting. Wacha sasa nizime. Yes. Yeah, leave the meeting or you are asleep. You slept. Good night, guys. We shall talk more next week, eh? No. The other week. Shall talk more the other week, eh? Bye-bye.